Hello, everyone. I'm Leonel August Rodriguez, the VP of Business Development for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insight from leading medical experts. We do ask that all questions are submitted via the Q&A, as they will be answered at the end of today's lecture. Today, we have a very special individual who has over 50 years of experience as a physician. He is the medical director, CEO, and the founder of California Age Management Institute. Without further ado, live from California, Dr. Philip Lee Miller.
Thank you, Leo. I
My
want to
pleasure.
thank you, and I want to thank Access Medical Labs for this opportunity to present you with a really unique presentation. You can go on YouTube and you can find a lot of information today with regards to lipids and cardiovascular disease. What I'm going to show you is a little bit different. I'm going to guide you through some history and ways of looking and critically evaluating what makes sense and what doesn't make sense. So, as Leo mentioned, I'm the director and founder of California Age Management Institute. We were the first center to offer full anti-aging services back in 1996. So we have quite a bit of experience, and I've actually been at this for 50 years in terms of looking at cholesterol and lipids. So without further ado, let's plunge into our presentation. So this is the challenge. Is cholesterol the culprit? And I'll even start out by saying that when I was in medical school, I was the first to say, I don't think cholesterol causes heart disease. And all my medical student buddies said, well, you're an idiot. Everybody knows that. So this is a story that goes back many decades. So the question is, what causes vascular disease? You really need to know the difference between genotype and phenotype. So you can look at genetics, but it doesn't necessarily mean you will express that. We used to call that incomplete penetrance. How can this be modified? What we're going to address today is statin therapy the answer? What are the factors that are overlooked? And it seems like what we're always looking for, because it changes every 5 to 10 years. What is the holy grail? What is the one test that we can determine your predictive value of developing any vascular or cardiovascular disease? So just as by way of history, Russell Wilder, and then more recently, Dave Asprey, who you may know, have been proposing the ketogenic diet. Interestingly, John Goffman in the 50s started at Donner Labs. This was really an outgrowth of Oppenheimer's work developing the bomb, which also originated at Donner Labs and the radiation lab at Berkeley. So the ultracentrifuge was first used to start separating various components of cholesterol. Ansel Keys is someone that people have referred to. Nathan Pritikin started in the 90s or late 80s with an emphasis on low fat, high carbs. Then Robert Atkins, who you know as the Atkins diet, which is sort of a modification of the keto diet, started with a high fat, low carb diet. Then Dean Ornish said, no, we want a low fat vegetarian meditation diet. So you can see how each person has developed a new proposal. Daniel Steinberg was professor of medicine at UC San Diego and a good friend who really worked on a lot of the lipid protocols through the NIH. Then Robert Saperko, who I considered my mentor, was one of the original people at Berkeley Heart Labs, where again, they went back to ultracentrifuge, doing gel centrifugation, gel separation of various components of lipids. So this is the original machine at Donner Labs where the ultracentrifuge started this off. Daniel Steinberg wrote this book, The Cholesterol Wars, and in it he said, we almost lost the war until we came upon statins because diet alone wasn't curing the problem. So you can see there's various authoritative authors who have written about this subject and the cholesterol myths. And finally, person that I knew quite well, Stephen Sinatra, probably one of the best alternative cardiologists, wrote this book about 10 years ago. So there's a lot of information out there. So what are the things that we need to know? What we need to know, and what's really a concept that I have to emphasize over and over again, is relative statistics are used to sell you a result or treatment. And so we go with hazard ratios and relative risk confidence limits, which are replacing p-values. And I can show you how you can really fudge this in terms of the visualization of risk by amplifying the x-axis or the y-axis. So here's sort of an example that I gave showing an untreated versus a treated, and you can see how it diverges after 8 years. There seems to be a difference. But if I change the y-axis, then it doesn't look so obvious. Again, another example of using relative statistic to show relative changes versus absolute statistics showing virtually no change. It's a concept that I'm going to emphasize throughout this talk, and something that nobody's really talking about, although this really was published in the New England Journal about 15 years ago, that we really need to concentrate on absolute versus relative. So again, studies showing that after time, you can see a divergence between treated and untreated. But again, if we change the y-axis, that difference there doesn't look as manifest. Again, just showing another, this is one of the famous lipid studies showing that out of 3,000, only 135. So the absolute amount here is not much. So if you look at the relative risk, it's 4.1 versus 3.2, and they said, okay, your hazard ratio is 0.76, but you can really see it's only this amount here. It's only like 1%, not 25%. So this goes to some concepts that I emphasize in my book: inflammation, oxidation, glycation, methylation, and then mitochondrial decay. These are really the most important determinants of cardiovascular disease. And as we age, we're subject to inflammation, oxidation, glycation, and methylation. So we can look at a more integrative approach, which looks at blood flow, viscosity, elasticity, calcium, vitamin D, vitamin K, and we'll go through these very quickly. And then mitochondrial decay, which is decreasing power output. So vascular health is not new. A man is as old as his arteries. This is Thomas Sydenham. So if you look at this here, and if we go back again, you can look at various points in the right ventricle, in the left ventricle, and you can see various points where there's blockages here. But you can see that what's not shown in an angiogram is this rich neovascularization that bypasses the main arteries. So we look at, and we used to think of cholesterol as just sort of depositing in the wall there. But in fact, really, you have to look at it as the intima and the media, and it's where the basement membrane gets penetrated. So if you look at right here, that's where the problem is. And so a normal artery looks like this, but an artery that now is developing plaque is between the intima and the media. And I'm going to emphasize something here. If you look at this, in reality, it's really like an abscess. That's really what this is, what a plaque is. It's a migration of monocytes and macrophages, and it's really white cells that is essentially an abscess. So you can see this is what it looks like as the lumen is narrowed. So if we look at complex lipids, that's the topic today. We look at, well, first there was cholesterol. But then we said, well, maybe there's more components. So we looked at cholesterol, and something that I emphasize to all my patients, total cholesterol is irrelevant. It's not what you're looking at. Really, and I'm going to emphasize this later, triglycerides are as big, if not a bigger risk factor. So we looked at HDL, which is reverse cholesterol transport. We looked at HDL2B, which is not available any longer. We looked at LDL. That's the current obsession. It's not total cholesterol, it's LDL. And now the latest one is, and it'll change every 5 years, it's ApoB. But VLDL tracks triglycerides. We look at ratios. And finally, what I've been looking at for the last 15 or 20 years is particle sizing, which is pattern A and pattern B. So here are some underappreciated factors that I test in all my patients. Fibrinogen thickens the blood, tendency to clot, heart attacks and strokes. It's an acute phase reaction. Lipoprotein A, LP little a, is highly atherogenic, but it's a non-standardized test. So every lab will give you a different range. Homocysteine is really important. I'm looking at homocysteine more and more as a renovascular risk because I see this after 10 or 20 years, high homocysteine levels, patients are developing kidney disease. We look at CRP and SED rate. They measure different fractions, but it's a good measure of inflammation, frequently related to glutamine or gluten. LPPLA2 was the plaque test, which is a risk marker. And we look at ferritin. Ferritin can be a marker for iron, but it's also an acute phase react that can measure inflammation as well. Furthermore, there's more underappreciated tests, which is LDL sizing, which leads to pattern A or pattern B. Pattern B are small LDL particles that are more atherogenic than pattern A. We look at small dense LDL, which is supposed to be much more atherogenic. We look at oxidized LDL, which I thought at one point would probably be the best biomarker of inflammation and a predictor. We look at F2 isoprostane. We look at TMAO. We look at triglycerides. Triglycerides are probably just as important as cholesterol. So here's a video that I'm going to show you.
Associated phospholipase A2, or LPPLA2, has been shown to play a role in the atherosclerotic disease process. Atherosclerotic plaque forms in the intima or wall of the artery. LPPLA2 co-traffics with LDL cholesterol in circulation. Within the intima, LDL can undergo oxidative modification. Upon oxidation of LDL, LPPLA2 hydrolyzes oxidized LDL, generating two highly inflammatory mediators, lysophosphatidylcholine, or lyso-PC, and oxidized fatty acid, or OXFA, which trigger a host of pro-inflammatory and pro-atherogenic activities, including cytokine production and the upregulation of adhesion molecules. These activities result in increased recruitment of monocytes to the site of injury and their subsequent penetration into the intima from the lumen of the artery. Once in the intima, monocytes differentiate into macrophages. These macrophages engulf the oxidized LDL trapped in the intima. Upon ingestion of oxidized LDL, macrophages develop into foam cells. These aggregate to form a fatty streak, which over time develops into an atherosclerotic plaque covered by a fibrous cap. Cytokines and proteases secreted by macrophages cause the thinning of the cap, making it prone to rupture. Plaque rupture can result in an atherothrombotic clot, which blocks the artery, leading to a heart attack or stroke. The FDA cleared.
So that will give you a good visual representation of what the process is. We look at mechanical stress. We look at viscosity. We can look at elasticity. We can look at calcium shifts with vitamin K and vitamin D. Difference between LDL and HDL particles. So here are the major studies. And again, what I've shown you is the atherogenic lipoprotein phenotype, pattern A, large, fluffy LDL particles that are less atherogenic, usually characterized by low triglycerides, maybe a slight rise in LDL, and a high HDL, as opposed to pattern B, which is usually characterized as low HDL, a rise in LDL, and are much more atherogenic. So what it means is the large HDL particles, the theory is they're not as likely to penetrate the intima, whereas the small LDL particles are much more atherogenic because they're much more likely to enter the intimal medial space and enter that inflammatory cascade. The previous video that I just showed you how many components are involved more than just simply cholesterol. This is a classification that has sort of fallen out of date, but I still think it's very useful. It's the Friedrichsen classification because it's basically categorized into 5 categories. And some of these are related to diabetes. Some of these are related to Alzheimer's. It's still worthwhile to know this classification. You can see this is a study that this is my compilation of all of the major lipid studies. And I went through and I looked at the actual numbers and I said, here are the relative statistics showing you there is a big difference when you use statins. Here are the absolute statistics. And here's the bottom line. If you look at the absolute statistics, you will see that on a population basis, there was no difference with statin therapy. But again, the caveat is population, and it's not based on genetics, and it's not based on age. So there's a difference between someone in their 20s, 30s, 40s, 50s, 60s, and 70s, and in a population. What we look at is, can we pick out that small number of people where this will make a difference and where it won't make a difference? Same thing here. And so Robert Saperko was really big on showing that cholesterol alone is not the best predictor of heart disease. Because if you look at the Framingham study that was at least 40 years old, probably now 50 years old, you could see those that had heart attacks and those that didn't have heart attacks had the same cholesterol. Heart attacks, no heart attack, same cholesterol. Cholesterol was not a good predictor. So we've looked at imaging, and imaging is the next phase of determining risk. There's the EBCT, which most people are not using, and there's the spiral CT, which is in general use. This one here is retrofitted. This one is dedicated. So this is what the EBCT looks like. And what we're looking at is we're looking at calcifications there. Furthermore, this is what we used to do in our office. We looked at carotid artery calcification or carotid artery plaques. So we look at studies showing that this may be a better predictor. This was actually on myself showing here was my predicted risk. And again, what we see here is intimal medial thickness. And intimal medial thickness is accumulation of foam cells based on cholesterol. And what we looked at is we looked at carotid artery. And do we see any plaque or not plaque here? This is still a useful test. And I was one of the only ones in the Bay Area using this specific machine. Furthermore, we looked at angiography. You can see here is a plaque and a stenosis. This goes back to my old chief of medicine at medical school, Braunwald, who's probably one of the most important cardiologists in American history. And even back in 1977, he said there's a growing enterprise developing of its own constituency, implying that angiograms would be the power to would be the tool He concluded that it might be a poor tool to assess atherosclerosis. Increasingly become apparent that the amount of narrowing is not the major problem here. So furthermore, we look at viscosity, which includes hematocrit, red blood cells, viscosity, other constituents, showing you once again that there are other factors involved here other than just simply looking at LDL or ApoB. So if you look at the carotid bifurcation here, which is the internal, external, you can see that there's eddy currents here, and these promote flow turbulence. And over time, this turbulence causes irritation. This irritation is the inflammatory impetus to start that plaque process. So just flow along, and this may be related to hypertension, but it's also just related to the turbulence in these particular areas, also showing how blood pressure will rise with age. So inflammation is associated with endothelial dysfunction. Endothelial dysfunction is related to nitric oxide, endothelin. CRP is really important. So what causes thrombosis, which is heart attack? It's the insult. So there's a Venn diagram showing large lipid, thin cap. We put all this together. Here is the lumen that's being narrowed. So we start out with a normal artery. It's eventually that plaque takes up the whole area there. When this reaches about 75%, then you're a surgical candidate. We're trying to prevent all of this. We're trying to prevent this migration. So again, I'm showing you that it's not just cholesterol, it's macrophages, and lymphocytes, and mast cells. It's blood flow, monocytes. What we see here is, this is what's really important. These are adhesion molecules. Again, inflammatory process, adhesion molecules, LPPLA2 starts this process here. And this shows a migration of the LDL particles, HDL, and this is the rupture of the plaque. So I'm a big proponent of nattokinase because nattokinase will prevent fibrinogen converting to fibrin. Fibrin plus platelets causes the clot. So the conventional answer is, well, your cholesterol is elevated, your LDL is elevated, your ApoB is elevated. We need to use a statin. So the statins operate really high in this cascade here between acetyl-CoA here, mevalonic acid, and eventually you get down to cholesterol. But what happens? What happens is that you're blocking it high up here, which means you're blocking the natural production of CoQ10, vitamin A, vitamin E, vitamin K, vitamin D. So all of these precursors here that are really important for cardiovascular health, you're blocking that. And this is a further visualization of all of the specific lipid fractions that are being blocked by using statins. They even knew this as far back as 1990. There was an abstract, there was a patent filed showing that CoQ10 should be used with all statins. So pharmaceutical companies even knew about this a long time ago, that when we block this pathway here, that you've got a problem with these cofactors down here, further down. And furthermore, I want to show you that if you block statins, you're blocking cholesterol, and cholesterol is also not only necessary vitamin D, bile acids, but sex hormones. So the conventional approach is Crestor, Lipitor, Mevacor, Pravachol. The ones that are in big use now are Lipitor. If I use a statin at all, which is on occasion, I'm going toward Crestor. Crestor is more brain friendly, and I'm using low doses. Coumadin and heparin have now given way to aspirin, Tyclin, Plavix. And even those are now giving way to the more common class 10A, which is the direct thrombolytic inhibitors, which is Xarelto and Eliquis or Eliquis. So this here, my problem with Coumadin and heparin is this over time will actually make cardiovascular disease worse because you're blocking vitamin K. It'll make it worse over time. Whereas these here, probably not quite as pernicious. This is the big controversy now. HDL trumps LDL. I still believe this. I still think that a high HDL is really as important as a low LDL. There's a lot of controversy surrounding this. And the controversy surrounding this is based on a failed study where they used Lipitor and a HDL enhancer. But the problem was they used both of these. In the end, what they found out was there's a difference between a low HDL and raising it and a native HDL that is high. A native HDL that is high is protective. What they couldn't find out is a low HDL, if you tried to raise that, did that lower risk. And so what you have here is you have this cascade here. I still think of HDL as a reverse transporters. The way I describe this to my patients is HDL is sort of like a vacuum cleaner. It's clearing the heart of cholesterol, whereas LDL is carrying cholesterol to the heart, normally for good reasons. So here are my therapies that I offer my patients. The goal is arterial reconditioning, rejuvenation, revitalization, re-energizing, optimizing, using micronutrients. So what does that involve? I'm really big on fish oils because they're anti-inflammatory. 5,000 EPA, 4,000 DHA has to be liquid. Caps will not give this to you. 300 to 600 milligrams of CoQ10. Carnitine really enhances transport of triglycerides being burned up in the mitochondria. Vitamin E really helps with rheology. Ribose enhances cardiovascular strength. Testosterone enhances cardiovascular mitochondrial strength. Bivel enhances estrogen. Estrogen really enhances cardiovascular youthfulness. And vitamin K. And I've gone into this in the past. I'm going to skip by this pretty quickly. But what I'm going to mention here is that MK7, which you may have heard about, is not as important as MK4 because the MK7 that most people are using is in small amounts versus large amounts of MK4. So my recommendation is 10 milligrams, which is 10,000 micrograms of MK4 versus 90 or 160 micrograms of MK7. Niacin's been used. I'm really big on this specific product that'll give you 10,000 of B12 and 3,400 of methylfolate. Heart friendly, exercise, high protein, low carbohydrate, no smoking, less alcohol, meditation, yoga, love, dental hygiene, avoiding chlorine. Some of these are ones that are not emphasized. Chlorine in the water is not good for you. Dental hygiene, we're understanding this more and more. And the one that's left out of here is also a healthy gut, is a healthy brain, and a healthy heart. Again, high-dose fish oils, turmeric, vitamin E, ginkgo biloba. This is my natural anticoagulant routine because it treats all aspects of coagulation. It prevents heart attacks and strokes. Fish oils, rheology, turmeric inflammation, rheology, antiplatelet, antifibrinolytic, antithrombotic. Protective effects of omega-3s, what we've seen with niacin, which we're all sort of backing off on, but again, showing you that DHA is probably the most protective. So what you want is less arachidonic acid, more EPA, more DHA. Good for your brain, good for your heart. Finally, the greatest risk factor, this is from Dean Ornish. Apart from everything I've just discussed, Dean Ornish said, the highest risk factor for heart attacks is disconnectedness. And we have a lot of that today. I talked to David Zava once and I asked him, what's the best way of reducing stress? And he said, love. He said, no, David, what drug or what nutrient? And he looked at me again. He said, love, connections. And then I started this 30 years ago. Will you still love me? Will you still care when I'm 64? And now a lot of us are beyond 64. So I've gone through this in fairly rapid fashion to give you the basis of discussion that follows. Begin showing you it's not just cholesterol. There's many other factors here. Heart disease is an inflammatory process. What are the things that we can do to reduce inflammation? What are the other factors that are involved in cardiovascular risk? And I've given you some sample of how I approach this in my own practice. This is 2005. It's still one of the best books out there. It elaborates many of the concepts I've just presented here. With that, I want to thank you for paying attention. And I think I've really kept to my schedule. So I've done okay, Leo.
You have done excellent, Dr. Miller. Thank you so much. We truly appreciate this very informational and educational lecture on cardiovascular health. We have quite a few questions in the Q&A. I will start with the first one. So, what are some limitations of using angiography to assess atherosclerosis?
Okay. So first of all, angiography, what you're looking at is the heart. So you're looking at coronary arteries, okay? So there's carotid arteries, coronary arteries, slightly different process. The limitation of angiography is what I've showed you is you can have a blockage. What you don't know is how much neovascularization is around that prevents that from becoming a major event. But I think the other limitation is when you do angiography, it almost always leads to a procedure. It's always going to lead to a stent. It used to be coronary artery bypass, it used to be angioplasty, but more often than not, today it's going to lead to stents. And the question is, do you want one stent, two stents, three stents, four stents, five stents? Is the stent going to last for more than 2 or 3 or 5 years? Is it going to have to be replaced? Is it a drug-eluting stent? So the limitation of angiography is it significant? And does it lead to a procedure that you need? Is it warranted?
Very good question. And excuse me for not pronouncing this correctly. Are tocotrienols, did I say that correctly? Tocotrienols?
Yes.
Okay, whoever named these, are tocotrienols a better form of vitamin E?
Great question. So I look at tocotrienols as a cousin to tocopherols. And again, if you look at all the studies on vitamin E, they're always on synthetic alpha tocopherol as opposed to tocopherol. So tocopherol is the most important one, and you're looking at alpha, beta, gamma, and delta. There are similarly tocotrienols. They're also alpha, beta, delta, and gamma, as far as I know. They are cousins. They're probably more potent. The one you want is gamma tocopherol vitamin E, and it may be the same thing with the tocotrienols. They say ideally you don't want to mix the tocotrienols and the tocopherols, so you take them at different times. But it's a great question. They're probably more potent. So it's a great question.
Excellent. And what are some heart-friendly practices and supplements you would recommend for maintaining good cardiovascular health?
Well, I think I've laid that out. The ones that I'm really big on are fish oils, anti-inflammatory, vitamin E. I use a lot of alpha lipoic acid, vitamin C, but I'm also really big on vitamin D and vitamin K. Those are the essential basic. I'm now really big on probiotics. Healthy gut is a healthy brain. Healthy gut is probably a healthy heart. And then I use a lot of enzymes.
Excellent.
Awesome. That's my core supplement list.
You just gave us a golden recipe, yes?
Yes.
Excellent. And what are the potential effects of statin therapy on CoQ10 levels?
So what I've shown you in this here is that the blockage is so high that the production, natural production of CoQ10 and other fat soluble nutrients is blocked. What I found is you'll read in the literature that there's only a small percentage of people who don't tolerate statins. It's not my experience. Now, maybe I have an unusual population, but I don't think so. I think it's really understated. The people who have problems with statins is a large number. It may be CoQ10 is one of those factors, because CoQ10 is really important for mitochondrial function. It's like in this first step of the electron transport system is dependent on CoQ10. So when I do a statin, I always recommend CoQ10, always. And that is one of the ways you can bypass all the muscle aches and some of the problems that you get with statins.
Excellent. And what would you say are some mediators involved in atherogenosis and thrombosis?
Well, again, what I've shown you is there are a number of mediators. There's physical ones, there's chemical ones. It's not just cholesterol. So we go back to vascular disease is an inflammatory disease. And anything you can do to reduce inflammation, fish oils will reduce inflammation. Gluten is inflammatory. Enzymes will reduce inflammation. Turmeric, curcumin. So there's a number of ways of reducing inflammation to reduce that process.
Excellent. And my last question, outside of the supplements, right? Any sort of lifestyle approaches to help in the reduction of inflammation?
So it's the foods that you're eating. What are inflammatory foods? And that's a whole other discussion. Some foods are inflammatory, some are not. Probably one of the biggest ones that I look at are dairy and gluten. Those are the ones that are most likely to cause inflammatory things. And the thing that you look at is you look at the CRP. CRP is going to be the first measure of inflammation, and the highest yield is going to be gluten or dairy products. Then you look at alcohol as inflammatory. And I've shown you there's a list of other things, even chlorine in your diet. That's just that's a first pass. First pass, gluten, dairy is going to be the ones. Cut down on alcohol, because what I tell people is alcohol is not healthy. So the only way that alcohol will help you is if you could have small glass of alcohol every night, you'd be okay. But nobody does that. Say, well, I'll have a half a glass of big goblet. I'm always trying to tell people less alcohol. And then smoking is definitely an inflammatory aspect.
How about sugary foods?
Try to cut down carbs as much as possible. I'm always working at this. So what I've shown you is the latest is whether it's the Atkins diet or the ketogenic diet, all of this is moving toward low carb, high protein. The only thing that is really still controversial is what do we do with fats? Because the ketogenic diet will tell you fats are okay.
Fair. And I know I said that was my last question, but I have one more.
Sure.
It's a very interesting question. I've never seen these two asked in the same manner. If cholesterol levels rise, especially HDL, is this an indication of toxins, metals, molds?
Well, this is a whole other lecture, metals and molds. Let me just, because this is a big controversy. So let me make it real simple. Never use aluminum cooking pots. Try to get chlorine out of your water. We're always trying to get lead, and that in California, everything is on Proposition 65. So we've tried to reduce lead. So you try to reduce those toxins as much as possible. But I think the easiest one is never cook in aluminum pots. And also never, if you're going to microwave, never microwave in plastic. Always put that in a ceramic or a glass vessel if you're going to microwave anything. So there's simple ways of looking at this. Then we can look at infrared saunas as another way of detoxifying yourself. But that's just a first pass.
Excellent. Excellent. Dr. Miller, once again, on behalf of Access Medical Labs, thank you for such an amazing lecture on cardiovascular health. To our audience, thank you for tuning into another Access Live, where we bring you insight from leading medical experts. Don't forget to like, subscribe, and stay healthy. Until next time.
And once again, thank you for everybody for watching. And this will take a few more passes, but I appreciate your attention.
Excellent. It's been a pleasure, Dr. Miller. Thank you again.